All right, welcome. This is the 2018 Matrix Telehealth Summit, and we welcome you to be here for being here. As you saw in your announcement this morning, Karen Rubin, who's my boss and our fearless leader, is unable to be here, but she's going to be joining us by video and doing the welcome. So let's go ahead and flip her on the big screen, and here's Karen.
Good morning, everyone. Kathy, can you confirm that you can hear me?
Yes, we can hear you.
Oh, wonderful. Okay, thank you. Well, sorry, my cat's jumping up. I want to extend my warmest welcome to the 7th Annual Mid-Atlantic Telehealth Resource Center Summit. I apologize for being remote this year, but being only 5 days into an episode of genuine influenza A, I'm happy to be both upright and able to welcome you this morning virtually, and you guys should be happy I'm not there too. This year's program will cover a broad range of telehealth topics and public policy discussions. And in addition, the planning committee has arranged an amazing set of sessions entitled Telehealth on Trial Scenarios, which will create lively opportunities for discussion. Huge and special thanks to Kathy and the entire planning committee and organizing committee for organizing such a wonderful event. And a special thanks to our colleagues in Pennsylvania for hosting us in Hershey. I've never been to Hershey. I understand it smells like chocolate, and I love chocolate. And to each of you for coming to MATRC 2018. I will be there next year, and I wish you a wonderful, wonderful summit. Back to you, Kathy. I'll hang on until I can't. So thank you again, everybody, for coming.
To do a formal welcome to Pennsylvania, I've asked Lisa Davis and Joe Tracy to come up and join us.
Good morning, everyone. Good morning, everyone. Well done. So welcome to Pennsylvania. This is my home state. I have lived here my whole life. Grew up in Pittsburgh, the steel capital of Pennsylvania and maybe the world, and make my home outside of State College. I'm the director of the Pennsylvania Office of Rural Health, and I serve on the board, the advisory board of Matrix, and along with Joe Tracy, who is somewhere right there. Okay. And also co-chair along with Joe the Telehealth Advisory Committee for the Pennsylvania Department of Health. So we're so happy to have you in Pennsylvania. And I want to share with you a couple of fun facts about our state. So, as Karen referenced, this is Chocolate Town. So Hershey is the chocolate capital of the United States. The state insect is the firefly. The oldest gas station in the United States is located in Altoona, Pennsylvania, which is in the central part of the state. The nation's oldest golf course is in Clarion, a beautiful rural part of Pennsylvania. The Philadelphia Eagles and the Pittsburgh Steelers merged in 1943 to form the Steagles for one season. They merged because they had lost so many players to military service during World War II. One weird Pennsylvania law forbids singing in the bathtub, so watch yourself. Another forbids the sweeping of dirt underneath a rug. The iconic banana split was born in 1904 in Latrobe, also home to the Rolling Rock Brewery. If any of you have, in your college days, had those pony bottles of Rolling Rock. I never did, I've just seen them. And Latrobe is home to the Banana Split Festival. The Philadelphia Zoo is the nation's first zoo. The mushroom capital of the world is located here in Pennsylvania in Kennett Square, where 50% of all the mushrooms grown in the United States are grown here in southeastern Pennsylvania. D.G. Yingling & Son in Pottsville is the oldest brewery in the United States and the longest running family-run brewery in the nation. So I know all of you have seen Yingling Brewery. Altoona is the birthplace of the Slinky, and Boalsburg, where I live, is the birthplace of Memorial Day. Punxsutawney citizens are proud to be overshadowed by Punxsutawney Phil, who lives in the town library. I do have to say, no one in the state believes any of his predictions. And this year, there is a death warrant out for that rodent. And finally, you might know that the Philadelphia Eagles are the Super Bowl champions. All right. And Villanova is the national basketball champion. So, woohoo and go Pennsylvania. So I've joked with Joe that I'm just the arm candy, and now I'm going to turn it over to him for some actual serious telehealth conversation.
Good morning, everyone. Okay, can we, one more time? Good morning. All right. My apologies to my friends in Kentucky. There are other Wildcats in the country. So go Villanova. And plus, let's see, I think we have 2 hockey teams in the playoffs and 1 basketball team in the playoffs. So are we becoming, this will sound bad, are we becoming the new Boston? So, well, anyway, welcome everybody to Pennsylvania. I've got some chocolate up here if anybody needs it. I'm sure we'll all be sugared up during the day. But anyway, I'm pleased to be here. Again, like Lisa, I am co-chair of the Pennsylvania Telehealth Advisory Committee, which is run by the State Department of Health, or the Commonwealth's Department of Health. And so I do want to introduce a few folks here that are really making a difference for us in Pennsylvania. One is the Chief of Staff for Senator Elder Vogel, Cheryl Schreiner. With her help, we have a bill in the Senate that's moving forward. I know nobody has an interest in reimbursement, but it is a reimbursement bill, and for Pennsylvania, that's a big deal. So we need to get this passed so we can move on with the reimbursement scheme. Cheryl, where are you? Would you like to say a few words at the mic?
Thanks, Joe. And I've worked with Joe and Lisa and Stephanie, who's soon going to be recognized, on a piece of legislation about, we've been working on it for about 2 years now. And Senator Vogel is from the western part of the state. He's about 40 minutes north of Pittsburgh. He's a dairy farmer by profession, so rural healthcare access is extremely important to him. As we took this process on, we realized that Pennsylvania is one of the few states that does not have a statutory definition of telemedicine. And I've actually looked to a lot of your states to see how your statutes have been structured, and been very helpful. But I went to a couple of the sessions yesterday, and as I think some of the speakers said, no telehealth program is the same, no statute seems to be the same in all of the states. So we've kind of picked certain parts. Some of them are consistent with other states, but some of them aren't. We've defined telemedicine to include remote patient monitoring and store and forward. We felt that that was very important to move forward with the proliferation of telemedicine. Licensure, we're going to ensure that health practitioners need to be licensed in PA. We establish a relationship between a practitioner and patient. We address standard of care, informed consent, electronic medical records, HIPAA, of course. We give the direction to the state boards to promulgate regulations, and we do have that insurance reimbursement component, which has consumed most of my time over the last year. We had started out with parity of not only parity and reimbursement, and also parity and practice. And we pared that down to just parity of practice, that if you are able to do it in person and then do it through telemedicine, that the insurer and the provider could then negotiate out what that payment would be. We were hopeful that that would bring the private payers along, but it has not. And we're still continuing those negotiations, but I remain hopeful that we will have a bill on the governor's desk by the end of the year, because it is, I think, imperative for the proliferation of telemedicine and just access to care, lack of specialists. As broad as PA is, it's a huge rural population. So, but glad to be here. Enjoyed the session so far. I'm able to stay for a little while today, but thanks, Joe.
Thank you, Cheryl. And I would be remiss if I didn't recognize Stephanie Ravito from the Pennsylvania Department of Health, who's been the glue that has held the Pennsylvania Telehealth Advisory Committee together over the last few years. And just as a way of thank you too, that whole program started as a result of a planning session that was supported by the Mid-Atlantic Telehealth Resource Center. So Stephanie, if you'll stand for a second. Thank you very much. And I would also be remiss if I didn't say thank you to Karen Ruban, Kathy Wibberly, Anita, and the whole gang from UVA who sponsor this program every year. I believe this is the 7th one. And to me, this is the best telehealth meeting in the country every year. So thank you for doing that. And again, welcome to Pennsylvania, and eat chocolate and hunt groundhogs.
All right, a few housekeeping things before we get started. So I want to recognize our sponsor, HRSA, who the Telehealth Resource Centers are funded by, and our grant funds result in us being able to provide technical assistance, also to host an event like this. And all of our services are free of charge when you come to us for technical assistance regarding building out, answering questions about telehealth. And Natasha is our representative from HRSA, Office of Rural Health Policy. So thank you. I also want to acknowledge our many, many sponsors and vendors in the exhibit hall, and just, can't reiterate enough that this event is not possible and not affordable for the majority of people if we didn't have all the sponsors. So I just want to give you a nudge to please help them come back each year by visiting them, having a good conversation with each of them. And I particularly wanted to thank Alan Izadpana from VitalNet and his team. They have been our star sponsors. I think this is our 3rd, possibly 4th year in a row, and that's amazing. So thank you very much for VitalNet. All right, so I'm going to invite our Telehealth on Trial first case to come up. So we have a tradition here at Matrix Summit of not reading bios. We'd rather use the time for people to actually give you the content. But while you have your mobile app out each session, and you can go to the one that's Telehealth on Trial 1, if you click on the name of the speaker, you can read their bio. And so we know that you are educated and you're able to read, so we don't need to read it out loud to you. So I'm going to have them just, they can introduce themselves briefly by name, and then you can read their bios in the app. And we will go ahead and get started.
Thank you, Your Honor. The plaintiff calls Dr. Robert Darling.
Good morning.
Good morning. State your name and address, please.
Dr. Rob Darling, Ashburn, Virginia.
Dr. Darling, have you, at my request, read the medical records in this case?
I have.
Have you also read the depositions of the patient, the defendant nurse practitioner, the director of the urgent care center, the emergency physician, and the neuroradiologist, and the different experts' depositions?
I have.
Have you, again at my request, formed an opinion that you can state to a reasonable degree of medical certainty whether, in its care and treatment of plaintiff, the urgent care center complied with standard of care?
I have.
What is your opinion, doctor?
The UCC breached the standard of care.
In what ways did the UCC, the urgent care center, breach the standard of care?
The UCC was the only source of medical care in Hopkins County. That means inevitably that from time to time it would have to evaluate patients for stroke. Each year, approximately 750,000 people suffer from stroke in the United States. Stroke is especially prevalent among the elderly, and the population of Hopkins County includes a high percentage of seniors. Nearly 3/4 of all strokes occur in people over the age of 65, and this patient was 64, certainly quite close to 65. And the risk of having a stroke more than doubles each decade after the age of 55. On average, someone in the United States has a stroke every 40 seconds. The duty to be prepared for a stroke is especially easy to understand when we think about its morbidity and mortality. Stroke is the third leading cause of death in the country. More than 140,000 people die each year from stroke in the United States. Stroke is also the leading cause of serious long-term disability in the United States. So it was entirely foreseeable that sooner or later such a case as this would appear at the UCC. It was also foreseeable that when a stroke or possible stroke case presented, it would be necessary to act quickly to avert a neurological disaster. The UCC was not prepared for the case, and it should have been.
What did the standard of care require of the St. Charles Urgent Care Center?
The UCC could have met this standard in one of two ways. It could have staffed the facility with someone able to diagnose stroke and distinguish it from other conditions. Had that happened, we probably would not be here today. The UCC may be tacitly conceding this point. In hiring a nurse practitioner with extensive neurological experience, it telegraphed its understanding that neurological problems in general, and stroke in particular, are highly prevalent.
Objection, Your Honor. The witness is speculating.
The UCC's job description specified that it sought practitioners with substantial neurologic experience, Your Honor.
Overruled.
Please resume your testimony. The question I posed and you started to answer was, what does the standard of care require of the UCC?
It was challenging to find a clinician with the needed skills to move to Hopkins County. The UCC had to come up with another solution. In 2016, when this case arose, the standard of care for a remote facility that handles such cases and was unable to recruit a doctor demanded the creation of telemedicine capabilities. Telemedicine technology is now widely available and quite reliable. Where the patient may have an ischemic stroke, that is, stroke associated with inadequate blood flow, the diagnosis must be made rapidly, because only when that happens can the patient be treated with the clot-busting medications technically called thrombolytics. The need for speed is especially pressing, whereas here, transport would likely be needed post-diagnosis. To be effective, these must be given quickly with no more than 4.5 hours after the onset of symptoms. It's estimated that without treatment, the patient loses 2 million neurons per minute and can never regain them. On the other hand, giving such medicines to a person with a hemorrhagic stroke, that is the kind associated with bleeding from a blood vessel, is not only not indicated, it would be a catastrophic mistake. Dissolving clots in a patient who is already at risk of death from bleeding would be exactly the wrong thing to do. So the UCC had to have the ability to distinguish accurately between these two types of strokes and to do so quickly.
You said stroke patients lose 2 million neurons per minute. What is a neuron?
A neuron's a nerve cell specialized in transmitting nerve impulses.
Have you formed an opinion that you can state to a reasonable degree of medical certainty whether the nurse practitioner complied with the standard of care?
I have.
Did the defendant, Ms. Jones, comply with the standard of care?
No, she did not.
Please tell the ladies and gentlemen of the jury how the nurse practitioner breached the standard of care.
Ms. Jones acknowledged her limitations in interpreting CT scans, yet she put herself in a position where skill in doing so could be a matter of life or death. She agreed to practice in a setting without telemedicine backup, where she should have either insisted that the telemedicine be provided at the UCC or declined the position. She knew that St. Charles is without any other medical care and is a long way from a medical center. Having willingly put herself into this predicament, she is in part responsible for the emotional trauma the patient experienced in being bamboozled into a terrifying ride aboard an aircraft, even more fear-inducing than an airplane.
Objection, Your Honor. There's no claim of fraud in this case.
Your Honor, there was no legitimate reason to subject Ms. Warren, my client, to the distress the defendant knew she would experience aboard the helicopter.
Sustained. The jury, that's you guys. The jury will disregard the implication that any deception was practiced here.
Thank you, Your Honor.
Dr. Darling, how would telemedicine have made a difference here?
A telemedicine consult would have allowed a more experienced, more highly trained clinician to evaluate the case, including the CT scans. This would have led to the correct diagnosis, sparing the patient the agonizing helicopter trip. The nurse practitioner was candid enough to acknowledge that her skill in reading the non-contrast CT was limited, but the UCC had failed to establish a mechanism for backup short of air ambulance transport to a place where the exam could be competently interpreted. Had telemedicine been available, the transport and all the stress and cost it engendered could have been avoided.
Could telemedicine have permitted diagnosis on the basis of a physical exam alone?
Probably.
What would one find on examination by distance care technologies that would permit making that diagnosis?
Well, first, the nerves supplied to the muscles of the upper face originate on both sides of the brain, whereas the innervation to the muscles of the lower face comes from the opposite side of the brain only. Secondly, when the cortex is injured, there's weakness in the lower face on the opposite side only. And third, when the facial nerve is injured, there's weakness in the upper and lower face on the same side of the facial nerve.
Did you, at my request, prepare some drawings to help illustrate these points?
I did. Can I have the first slide, please? In Figure 1, we have the pathway of the facial nerve. Note Panel A first. In Panel A, the innervation of the muscles of the upper face originates on both sides of the brain, whereas the innervation to the muscles of the lower face comes from the opposite side of the brain only. Note in Panel B, where the cortex is injured, signified by the red X, there's weakness in the contralateral lower face only, that is the other side. In Panel C, when the facial nerve is injured, as noted by the red X, there's weakness in the same side or ipsilateral upper and lower face.
Thank you, Doctor. Let me show you Exhibit 2 and ask if you could explain that as well.
Thank you. May I have the next slide? Thank you. Figure 2 shows patterns of facial weakness. Note in Panel A the normal anatomic landmarks that we see during smiling and raising of the eyebrows. In Panel B, which notes essentially a stroke, on the left, the nasolabial fold is flat and the mouth is turned down, but the forehead wrinkles are intact and the palpebral fissures are symmetric. In Panel C, which is a Bell's palsy, on the left, the nasolabial fold is flat, the mouth is turned down, the forehead is not wrinkled, and the palpebral fissure is widened. These findings are subtle, but they can make the differentiation.
Thank you, Doctor. Could you tell us about telemedicine's track record in managing stroke?
Telemedicine technology permits transmission of high-resolution images of portions of the human body and of diagnostic images such as CT scans. When at the patient's location no one is available or has the skills needed to make the call, telemedicine allows the information needed to do so to be provided to someone who offers the relevant expertise. In 2016, the American Heart Association and the American Stroke Association issued a joint statement called Telemedicine Quality and Outcomes in Stroke, Based on an extensive literature review, these experts determined telestroke technology is one of the most successful applications of telemedicine, bringing the experience of stroke experts to hospitals lacking appropriate stroke expertise.
Objection, Your Honor, hearsay.
It's a learned treatise, Your Honor.
Overruled.
Had the patient had a stroke, could she have been treated?
Yes,
How could she have been treated?
with the so-called clot-busting drugs known as thrombolytics.
Explain why clot-busting drugs are so helpful to ischemic stroke patients.
As noted, there are two kinds of stroke, ischemic and hemorrhagic. In the former, a clot blocks blood flow between the point where the clot is formed. As a result, tissue, depending on that flow, is deprived of blood and dies. When the tissue that dies is in the brain or spinal cord, the function served by the dead cells is permanently lost. As a result, the patient loses the ability to perform that function. Depending upon what part of the brain is involved, and assuming the patient survives, it might be speech, walking, hand movements, etc. In hemorrhagic stroke, as the name suggests, there is a bleed inside the head. A mass of blood outside the bloodstream does not deliver oxygen to the tissues nor remove waste. Instead, it compresses surrounding brain tissue, interfering with its function and damaging it. Again, brain tissue dies and cannot be recovered. In patients with ischemic stroke who are treated timely, survival approaches 95%. In most, neurological function remains intact except for imperceptible weakness. In other words, patients experience no significant long-term harm. Since most, 85% of strokes are ischemic, we have the ability today to protect the great majority of stroke patients from a life of handicap and deficits.
Thank you, Dr. Darling. No more questions, Your Honor.
Do you wish to cross-examine counsel?
I do, Your Honor. Thank you. Good morning, doctor.
Good morning.
Have you ever missed a diagnosis?
Rarely.
Did each such time when you missed the diagnosis constitute a breach of the standard of care?
No.
And that's because the standard of care doesn't require perfection, right?
That's correct.
Do you know any healthcare professional who has never missed a diagnosis?
No.
Now, what we have here, you agree, is that the patient did not, in fact, have a stroke.
That's correct.
And so she certainly did not have an ischemic stroke.
That is correct.
And so there was no reason why she would have required clot-busting drugs.
Correct.
Had she had a stroke, we can agree that the consequences could have been grave, as you yourself testified.
Agree.
Stroke kills people,
Indeed.
and it can leave them helpless.
Correct.
Now, that means that stroke, in its prevalence, let's see, your figure was something like 140,000 people per year, or sorry, 340,000 people per year die of stroke. Well, given that the population of the little town where this took place, St. Charles, is only a couple of hundred, that means stroke would have been sufficient to wipe out the population of St. Charles about 500 times over, right?
Conceivably.
Well, even among those that survive, stroke is a very serious problem, is it not?
It is.
Stroke is the leading cause of serious long-term disability in the United States,
That's correct.
whereas Bell's palsy generally leaves the patient intact with good long-term survival.
That's true.
So that if the plaintiff has Bell's palsy, she's far better off than if she had had a stroke.
Agree.
Now, you claim that the urgent care center could have staffed the facility with someone more capable of diagnosing stroke.
Correct.
But you don't actually know that, do you?
I do not.
You ever been to St. Charles, Kentucky?
Just for my honeymoon. Just kidding. Just kidding. No, I have
And
not.
while you were there on your honeymoon, did you make any effort to find out what kind of employment opportunities might be available to the spouses of doctors?
I did not.
Did you look into the cultural life of the community?
I did not.
Or the educational opportunities for the children of physicians who might go there?
No,
Did you even inquire about such things?
I did not.
Now, you testified that the town can't get a doctor, so therefore what it should have done was to establish a telemedicine service.
I believe that.
Is there any town in Kentucky, doctor, that is somehow immune from the risk of stroke?
No.
How many urgent care centers do we have here in Kentucky, sir?
I believe there are 86.
And in how many of those is telemedicine offered?
Approximately 5 to 10%.
So it's your testimony then, given that the standard of care requires telemedicine capabilities, that something on the order of 90 to 95% of the urgent care centers in Kentucky are violating the standard of care. Isn't that your logic, sir?
Yes.
Now, had telemedicine been employed, your theory is that the person who read the film, read the study, would have been more experienced than my client, Ms. Jones, right?
That is correct.
But in fact, you have no idea who would have been called upon to read that study had it been transmitted somewhere else.
True.
You don't know what level of knowledge, skill, training, or experience that person might have had or lacked, do you?
I do not.
You do know that even experts, even you yourself, make mistakes. Isn't that right?
Yes, but very rarely.
Well, good for you. So even if someone were, in fact, more highly trained than Ms. Jones to read the CT scan, there's no assurance that the outcome would have been any different. Now, is there?
That's correct.
So you have no way to know whether a telemedicine functionality would, in fact, have avoided the air transport or not.
Correct.
Now, telemedicine, of course, to be effective requires the internet, does it not?
Of course.
And so if you're going to provide telemedicine services, you need to have bandwidth sufficient to make that possible, don't you?
That is correct.
Bandwidth has to do with the speed of transmission, does it not?
True.
And if transmission speeds are slow, the images presented may be inaccurate or misinterpreted.
Yes.
And in fact, if you're attempting to do neurological diagnosis, if a slow transmission speed distorted the image, you might actually see a tremor where none exists. Isn't that true?
Conceivably.
Did you ever find out what sort of video capabilities exist in St. Charles, Kentucky, doctor?
It was down during my honeymoon, so no.
Do you know what access to the internet is there in Kentucky, in St. Charles?
I do not.
So if access were bad, telemedicine might not have been possible.
That is correct.
Or if it were possible, it might have been very slow.
That
Correct?
is correct.
Now, let's talk about my client, Mary Jones. You're aware that Ms. Jones is a nurse, are you
Of course.
not a doctor?
Yes.
Right. Now, nurses are in the business of helping people, are they not?
Of course.
And nurse practitioners do the same, only with a higher level of skill and training.
That is correct.
Nurses do help people in small towns, the kinds of small towns that physicians like yourself often avoid. Isn't that true?
That is correct.
Such as St. Charles, Kentucky.
True.
Now, you claim that Mary should have either insisted that telemedicine be provided or refused the opportunity to work in the urgent care center. Isn't that your theory?
I do.
Let's consider those options, doctor. Mary's job is to care for patients, is it not?
It is.
She doesn't run the urgent care center, now does she?
That is correct.
She doesn't control its decisions.
That is correct.
You can't say that had she requested telemedicine service that any such service would have been provided, now can you?
I cannot.
Now, the other option you offered was that she could have turned down the opportunity to work there at all.
Yes.
Now, you're aware, are you not, that in the county, and indeed certainly in St. Charles itself, the only health care available was through the urgent care center, right?
I am aware.
And that the urgent care center had had trouble hiring staff.
I am aware of that as well.
It takes quite a commitment to work in St. Charles, Kentucky, does it not?
Oh, yes.
Had Mary turned down the job, there's no way to know whether anybody would have stepped up to the plate, is there?
True.
So besides lacking a hospital and physicians, your theory is that Mary should have complied with the standard of care by leaving the people of St. Charles, Kentucky without a health care professional of any variety. Isn't that right?
Well, not exactly.
Well, the urgent care center tried to get other folks to work there, did it not?
It did.
Had limited success.
True.
But Mary, in full compliance with the greatest traditions of her profession, was willing to put all that aside and to serve the people of St. Charles, wasn't she?
Indeed.
What do you have against the folks of St. Charles, Kentucky, Doctor?
Nothing.
Anything
Nothing
else?
further, Your Honor. Thank you.
Call your first witness, counsel.
I take it the plaintiff rests.
The plaintiff rests.
Thank you. Okay, Doctor? The defense calls Dr. Jonathan Ball. Good morning, Doctor.
Good morning.
Could you state your name and address, please?
It's Dr. Jonathan Baugh in St. George, Utah.
Have you, at my request, read the medical records in this case?
I have.
Have you also, at my request, read all the depositions, that is, of the patient, the nurse practitioner, Ms. Jones, the director of the urgent care center, the ER physician, the neurologist, and that of the plaintiff's expert whom we just heard from?
I have.
Have you, again at my request, formed an opinion whether, in its care and treatment of the patient, the urgent care center complied with the standard of care for a reasonably competent urgent care center in Kentucky?
I have.
What is that opinion, please?
That the urgent care center complied with the standard of care.
Why do you conclude that the St. Charles Urgent Care Center, in its care of Ms. Warren, complied with the standard of care?
Well, the urgent care center is not an emergency department. It's just an urgent care center. The two differ with several respects. Number one, the scope of conditions treated, and two, the equipment and facilities available on site. Urgent care centers are usually not open 24 hours a day. Most of them open about 7 o'clock in the morning. Many close about 7 o'clock at night. Some close at about 11 o'clock. Emergency departments are open 24 hours a day. Many urgent cares are even closed on one weekend day. Occupational medicine is a significant component of the services provided by many urgent care centers, with more than 9 in 10 centers providing such services, including this one. Mainly, this means workers' compensation evaluations and case management, but to a lesser extent, urgent care centers provide other occupational medicine services, such as employment-related physicals, drug testing, treatment of illnesses and injuries. Occupational medicine matters do not require the capacity for rapid diagnosis or treatment, nor do they usually entail management of potential life-threatening problems. Emergency rooms, emergency departments generally do not offer services such as these. They are geared to handling more acute problems. Urgent care centers do not offer surgical services. As a rule, particularly invasive surgical procedures, that's any procedure that requires the use of regional or general anesthetics, procedures requiring a full operative suite or an operating room, or having lengthy recovery times, or requiring more than the level of imaging or specialists available at the urgent care centers. Urgent care centers are not emergency departments and should not be judged as though they are. Urgent cares offer convenience and are equipped to handle a variety of problems. But it is not realistic to think that they can or should be equipped to handle even the most serious conditions. That's just not what they're there for. Another clear distinction between urgent cares and ERs is EMTALA. That's the Emergency Medical Treatment and Active Labor Act that requires emergency rooms to provide a medical screening exam when a request is made for examination and treatment for an emergency medical condition, as defined, including active labor, regardless of the patient's ability to pay. Hospitals are then required to provide stabilizing treatment for patients with emergency medical conditions. If a hospital is unable to stabilize a patient within its capability, or if the patient requests, an appropriate transfer should be implemented. No similar law applies to the urgent cares. That makes sense. Emergency rooms generally take care of sicker patients than urgent cares do. The criticism leveled at the urgent care centers might be fair if we had an emergency department here. We don't.
Thank you, Doctor. In 2016, what percentage of urgent care centers had CT capabilities?
Somewhere around 6%.
Did the standard of care require St. Charles Urgent Care Center to have a CT scan?
Not at all.
It's been alleged that the urgent care center should have provided telemedicine capabilities, telemedicine support. Does the standard of care require that?
No, sir.
So the standard of care does not require the urgent care center to offer telemedicine?
No.
Why not?
Well, the standard of care is defined by what other reasonably competent urgent care centers do. So to identify the standard, we need to look at the other urgent cares. There are about 7,100 urgent cares in the U.S. right now. A few of them offer telemedicine. In 2009, a study by Winnick et al., and none of the UCCs identified by a multi-pronged national survey offered telemedicine. Not one. The standard of care for the urgent cares is defined by what is done at other urgent cares. The urgent cares do not offer telemedicine. By definition, the urgent care here conform to the standard of care for urgent cares.
In 2016, what percentage of urgent care centers offered telemedicine?
About 5 to 10%.
Why don't urgent care centers more widely employ telemedicine?
Now, most of the time, urgent care centers deal with problems that do not require telemedicine. If a provider at an urgent care center feels the need to confer with someone else, the phone is usually enough. Because urgent care centers, patients are usually and normally pretty healthy. If there are also legal barriers to it, reflecting the law's concern for patient safety.
What are the safety concerns?
Well, the physician is not in the physical presence of the patient, and so cannot carry out a complete physical exam. A complete physical exam has 4 components: inspection, palpation, percussion, and auscultation. With the telephonic communication, essentially none of these are possible. Even with video conferencing, palpation and percussion, 2 of the 4 steps in a complete physical exam are impossible. Palpation relies on the sense of touch. When the doctor palpates your abdomen, for example, he is looking for tenderness, enlarged organs, masses, and so on. Percussion is tapping on a structure to generate a sound, the way you might tap on a barrel of water or a watermelon to see how much water or how ripe the watermelon is. Some diagnoses depend on these 2 forms of examination. Auscultation, listening with a stethoscope, may or may not be possible with telemedicine. Diagnosis depends on part on physical exam, and so diagnosis impeded by an inability to perform a proper physical exam can lead to the wrong conclusion, the wrong treatment, and poor results. Telemedicine might be okay for psychiatry, for example, where physical exam is usually not very important. In other fields, it's a poor fit.
Do these safety concerns apply to patients like Ms. Warren?
Yes.
Why is that?
Now, this patient had a neurological problem. That is, she had something wrong with her nervous system. Neurology is a specialty in which physical exam is especially important, and skilled examiner can determine a great deal with his own 2 eyes and his own 2 hands. That is when he can touch the patient. A full neurological exam cannot be done via telemedicine. A full neurological exam includes testing the strength of the patient's muscles by having him move them against the examiner's resistance. Patterns of weakness can help localize a lesion to a particular cortical or white matter region, spinal cord level, a nerve root, a peripheral nerve, or a muscle. The term cortical that I just used refers to relating to the outer layer of the cerebrum. The cerebrum is in the top and front of the brain and is responsible for integrating voluntary body activities. White matter affects learning and brain functions and acts as a relay and coordinates communication between different brain regions. A nerve root is the initial segment of a spinal cord. Peripheral nerves are those outside the brain and spinal cord. By doing a full formal neurological exam in person, it is possible to identify where the problem is, where the brain is not getting enough oxygen.
Now, you mentioned that in a full, proper, formal neurological examination done in person, one tests the strength of the patient. What else does a patient such as this require?
A proper neuro exam also includes testing plantar flexion to learn about the tibial nerve, or dorsiflexion to assess the deep peroneal nerve. These tests require the doctor to be in the physical presence of the patients. When you do a neuro exam in person, you can check the patient's sense of touch. The patient should be able to, for example, distinguish one needle prick from two needle pricks, even if they are close together. He should be able to sense light touch, such as with a cotton swab, temperature, vibration, and joint position. These can and are done in person. They cannot be done remotely. Yet, like the other tests I mentioned, they are all part of a complete neurological examination, is proper in considering possible strokes. In a telemedicine exam, you cannot test the patient's reflexes as you can in person, nor can you readily evaluate the cerebellum as by finger-to-nose testing. The cerebellum is the part of the brain at the back of the skull. It functions to coordinate and regulate muscular activity. When the patients got to the larger hospital, what was the first thing Dr. Black did? He performed a full and complete neurological evaluation of the patient. Finally, follow-up is often a problem with telemedicine, especially where the physician sees the patient on demand and not on an ongoing basis. In a stroke case, you'd want the patient to be admitted and then followed up as an outpatient for a time.
Does telemedicine always make for a positive difference?
No, not at all. It's just a tool. Like any tool, it can help in some situations and not in others. In teleradiology, it is often the case that after an initial interpretation is made, while the patient waits, a formal reading is made the next morning. Often, the second read corrects the first. So diagnosis based on initial reads and in stroke medicine, where time is not available for any others, can often be wrong. Had a telemedicine evaluation been offered here, there was a fair chance that the reading would have been wrong. That's especially so where, as is often the case, the images are sent in an academic medical center at night. Then young doctors in training called residents read the images, but the images have to be read a second time, and often the interpretations have to be corrected by the professors in the morning.
How well do we understand the problem of erroneous initial reads in a circumstance such as this?
We don't understand it very well, but we know it is a problem. For one thing, the reading radiologist may be sleep deprived. For another, the number of radiologists available at night is often quite limited. If they get busy, they can't spend as much time looking at each image, and they face a greater risk of missing something.
Have you formed an opinion that you can state to a reasonable degree of medical certainty whether, in her care and treatment of the patient, Ms. Jones complied with the standard of care?
I have.
What is that opinion, please?
Mary Jones did comply with the standard of care.
Why have you determined that Mary Jones, in caring for this patient, complied with the standard of care?
Well, Ms. Jones performed a standard physical exam and made the same findings that subsequent examiners, including physicians, made. She recognized that stroke was a distinct possibility and that if the patient were having a stroke, she needed to be cared for in a facility equipped to deal with that problem, and quickly. She showed considerable judgment and commendable humility in deciding not to cavalierly rely on her own read of the study. Instead, with the patient's well-being uppermost in her mind, she very courageously called in an air ambulance to bring the patient to a place of greater safety.
But the final read of the CT scan was the same as hers. Would not the standard of care then have required her to realize that she was a capable reader of CT scans and so could have relied upon her own interpretation?
No.
Why not?
Well, because like all of us, except for Dr. Darling, she could have made a mistake. She was honest enough to admit to that. She did not gamble with the patient's life. Instead, she made arrangements for rapid transport to permit a more thorough and sophisticated exam at a larger center. That kind of caution saves lives, sir.
But it's been claimed that she should have demanded that the urgent care center provide telemedicine services or else refuse the position offered to her. Is that a fair criticism?
No, I don't believe so, sir.
Why not?
As an employee of the urgent care center, the nurse practitioner was not in a position to make demands of management. She knew that Hopkins County is a medically underserved area. She also knew that the probability of attracting more highly trained professionals there was slim. Rather than allow the people of the community to languish for lack of care, she stepped up to the plate. Now she is being criticized for her devotion to patient care and her willingness to work in what may, at times, have been challenging circumstances. She not only met the standard of care, she exceeded it.
Well, it's clear that Ms. Jones did not, in fact, reach the correct diagnosis of Bell's palsy. In failing to make the correct diagnosis, did she breach the standard of care?
No.
Why did the standard of care not require Mary Jones to correctly diagnose this case?
Well, in medicine, there's an old saying. It says, when you hear hoofbeats, think horses, not zebras. That means that to think of common things happen commonly. Strokes are as common as pig tracks in southern Georgia, and Kentucky is part of the stroke belt. By comparison, Bell's palsy is rare. There are only about 15 to 25 cases per 100,000 population. According to the 2010 census, St. Charles has a population of 287. Ischemic stroke incidence was 545 per 100,000 in 2008. For hemorrhagic stroke, incidence was 94 per 100,000. Combined, these two forms of stroke are about 25 times more common than Bell's palsy. Moreover, the cost of missing a stroke is exorbitant. Death, permanent disability. The cost of missing of Bell's palsy is far less so. Few nurse practitioners would have picked up a Bell's palsy in this case.
She's been attacked for causing this patient to fly. Do you agree that the standard of care required her to avoid the air transport that she ordered?
No.
Even though the patient feared flying?
Correct.
And why have you concluded that under the standard of care, Ms. Jones was justified in requesting air transport?
Because the potential alternative was far, far worse. A stroke is a neurological catastrophe. A stroke patient can certainly die. If he manages to survive, he may be a cripple, may be blind, unable to speak, unable to manage urination or defecation. The stroke patient may become entirely dependent on others for activities of daily living. Every treatment decision every provider makes entails a risk-benefit analysis. No treatment is free of risk. No treatment always succeeds. Every treatment has the potential to cause harm. The provider's job is to make a judgment based on the evidence at hand to act or not to act, and the nurse practitioner did so. Given a choice as she saw it between exposing the patient to a safe, but for her frightening trip, and missing a potentially fatal diagnosis, the nurse practitioner made the right call.
No further questions, Your Honor. Thank you very much, Doctor.
You have a very nice tie.
Thank you.
Do you wish to cross-examine counsel?
We do, Your Honor. Good morning, Doctor. How are you?
Wonderful, just like your shoes.
Thank you. You told us a bit about the kinds of patients urgent care centers see, correct?
Yes.
And my opponent went to some trouble to point out that stroke is common, correct?
Correct.
You know who I mean, right? The defendant's lawyer over there who's paying you?
Objection, Your Honor. Objection, Your Honor. The plaintiff has paid her witness just as we have paid ours. Experts are paid for their time and expertise, not for their opinions.
The jury deserves to know that the witness is being compensated for what he says, Your Honor.
Sustained. The jury will disregard that characterization.
At least on that point, that stroke is common. Is the defendant's lawyer correct?
Yes.
Would you say that stroke is really common?
Fairly so.
Would you say that it's so common that it would be hard to do primary care without seeing it?
Yes, I would.
Primary care refers to the care that you get in a community as opposed to specialized care at large fancy hospitals, for example, correct?
Yes.
Would you agree that this is the kind of care a family doctor might provide if you had one?
Yes.
Is this the kind of care you'd get in an urgent care center?
Yes, it would be.
So if an urgent care center opened its door for the first time this afternoon, odds are it will see a stroke patient pretty soon, correct?
Yes.
Would you see a stroke patient first day?
Maybe.
What about after the first week?
Possibly.
So would it come as no surprise if a stroke case is brought in?
No.
Do you recall when you told us earlier about a number of things that urgent care centers do not usually do?
I do.
Now, to operate a telemedicine service, there's no need, is there, for surgical procedures?
No, ma'am.
And there's no need to do any procedures requiring the use of regional or general anesthesia, correct?
That is correct.
And no need to do procedures requiring a full operating room or suite or have lengthy recovery times. Would you agree?
That is true.
In fact, telemedicine is in use every day all over America, is it not?
It is.
And it has been for years, right?
True.
Now, you told us about some paper by somebody published in 2009, eternity ago, did you not?
I did.
It's been almost a decade since then, since its publication, correct?
That is correct.
Would you say a lot has happened since then in the development of telemedicine?
Many things.
And in fact, nowadays, you find telemedicine services in clinics, correct?
Yes.
What about drugstores?
Yes.
Even patients' homes?
Some.
And even the homes of patients in small towns and remote areas?
Some.
In Kentucky?
Probably.
And in urgent care centers as well, correct?
That would be true.
These entities don't seem so concerned about the issues of safety arising out of telemedicine now, do they?
Evidently not.
And in fact, the safety record of telemedicine is excellent, is it not?
It is.
Let's explore this. Would you say it's non-invasive?
It is non-invasive.
And there's no risk of, say, infection, is there?
That is true.
Of pain?
No.
There's no need for anesthesia.
Correct.
Could you get a telemedicine consult right now, right here in this very courtroom, doctor?
I could.
Now, boards of medicine and boards of nursing create rules to protect the public, right?
Yes.
And certain practices are not permitted because they pose undue risk to patients, correct?
Correct.
Telemedicine service is legal and permitted in all 50 states, is it not?
It is.
And telemedicine services can be provided even if the doctor has never previously seen the patient, correct?
That is true.
And with video conferencing, you can in fact take a history, right?
You can.
Could this history be just as complete as one taken in person?
It can.
Could you observe a patient via telemedicine?
Yes, you can.
If you're worried about stroke, could you ask him to smile?
You can.
A patient with stroke may not smile normally, doctor, would they?
That's true.
With video, you can see how they smile just as well in person, correct, doctor?
That is true.
Via telemedicine, could you see them frown?
Yes.
Could you hear them speak?
You could.
Could you see them move their arms and legs?
Yes.
What about movement of the eyes? Could you see that?
Yes.
Could you ask them to close their eyes?
Yes.
Could you test their hearing?
Yes.
How about their vision?
Yes.
Could you ask them to stand up and walk
You could.
or sit down?
You could.
These are examples of tests that can be done by video just as they can be done in person, correct?
They are.
Can they be helpful in diagnosing stroke, doctor?
They can be.
You talked about strength testing earlier, correct?
I did.
But if a patient can rise from a chair and walk, that's not a bad way to check out his legs, is it?
It is not.
And if you watch him raise his hands above his head to put them out to the side or to hold them out in front at the same level, could you determine his ability to hear and understand commands?
You could.
Could you determine his ability to move his arms?
You could.
And could you determine the strength of one side versus the other?
You should.
You talked about the sense of touch, but if you're worried about whether it's a possible stroke, the sense of touch is pretty far down in the list of concern, is it not?
Well, not necessarily. An impaired sense of touch would make stroke more likely.
Well, could you sense that via the vibratory sense?
Yes.
You testified earlier that EMTALA is not applicable to the urgent care center, correct?
True.
But a standard of care does apply to urgent care centers. Even you admit that, right, doctor?
Yes, correct.
And the standard of care requires the urgent care center to be reasonably prudent, correct?
Yes, it does.
Is it reasonably prudent for an urgent care center to imagine that we'll never be called upon to handle the stroke case?
No.
Is it reasonably prudent for an urgent care center to imagine that when it does have to care for a stroke patient, it can take its own sweet time to get around to dealing with it?
No, ma'am.
Let's talk about video conferencing, doctor. Had video conferencing been available here, could a neurologist at a distant location have seen my client's face?
Yes.
Could he or she have seen that all the findings were on the right?
Yes.
Could he or she have seen that both the upper part and lower part of the face were affected?
Yes.
Now, a neurologist is a doctor with special training in diagnosing and treating diseases of the nervous system. Is that correct?
That is correct.
Neurologists are experts on stroke, are they not?
That is true.
A neurologist would know that in a stroke, the lower part of the face is affected, but not the upper, correct?
Correct.
A neurologist would also know that in Bell's, both upper and lower face are affected, would they not?
They should.
And even without the CT, a neurologist would have been able to sort out stroke versus Bell's palsy, could they not?
You would hope.
And with CT, he'd just have the icing on the cake, correct?
Reasonably thinking.
For Bell's, you wouldn't need to quickly send my client, Miss Warren, to a large, expensive hospital far away, would you?
No.
And you wouldn't have to subject her to a helicopter ride, would you?
Correct.
Let's talk about this harrowing helicopter ride. The theory of the defense is that by sending poor Miss Warren onto a large hospital, she could get better care, correct?
That is the theory.
But my opponent went on at some length about the uncertainty of referral. So let me ask you, the nurse practitioner has no way of knowing who's on duty at the larger hospital, does she?
No, she does not.
She could not know the level of expertise the person on duty would have achieved, correct?
Correct.
She had no way of knowing, regardless of experience, whether he have gotten the diagnosis right, correct?
That is correct.
And she had no way of knowing how much sleep he would have gotten, correct?
That is true.
And but she did know that my client, Miss Warren, was terrified of flight, correct?
That is true.
And in order to run the helicopter gauntlet, Miss Warren would have been sardined into a tiny compartment, correct?
Yes.
Doctor, let me show you Exhibit 3, already admitted. Do you recognize this picture, Doctor?
I do.
This is the interior of the egg beater the defendants forced my client to squeeze herself into, is it not?
Yes, ma'am, I believe so.
Well then, good thing my client is skinny, isn't it, Doctor?
No comment.
You all done?
No more questions, Your Honor.
Anything else, counsel?
No, Your Honor, the defense rests. Thank you.
All right. Now that you've all heard the evidence and the arguments of the attorneys, it is my duty to give you instructions as to the law applicable in this case. It is your duty as jurors to follow the law as stated in the instructions and to apply the law to the facts you find from the evidence. You are not to single out one instruction alone as stating the law. You must consider the instructions as a whole. You are not to be concerned with the wisdom of any rule of law stated by the court. You must apply the law given in these instructions whether you agree with it or not. It is your duty to determine the facts, and in so doing, you must consider only the evidence I have admitted in this case. The term evidence includes the sworn testimony of the witnesses and the exhibits admitted in the record. It is your own interpretation and recollection of the evidence that controls. You guys, you should be pulling up the live poll. It's going to pop up here shortly. You are permitted to draw reasonable inferences, deductions, and conclusions from the testimony and exhibits which you feel are justified in the light of your own common sense. In saying that you must consider all the evidence, I do not mean to suggest that you must necessarily accept all of the evidence as true or accurate. You are the sole judges of the credibility or believability of each witness and the weight to be given to the testimony of each witness. In determining the credibility of any witness, you must properly consider the demeanor of the witness while testifying, frankness or lack of it, and his or her interest in the outcome of the case, if any. The statements, objections, and arguments made by the lawyers are not evidence, and what the lawyers have said to you is not binding upon you. The rules of evidence permit a witness who by education and experience has become an expert in any art, science, or profession to state an opinion as to the matter in which he is versed, or she is versed, and which is material to the case, and he may also state the reasons for such opinion. You should consider such expert opinion and give it such weight as you, in the application of your common sense, may think it deserves. If you should conclude the reasons given by the expert witness in support of his or her opinion are not sound, or that his or her opinion is outweighed by other credible evidence in the case, or by the opinion of some other expert, then you may reject the opinion of such expert in whole or in part. It was the duty of the Urgent Care Center, in acting through its clinical staff, to exercise toward the plaintiff that degree of care and skill which is expected of reasonably competent medical personnel acting under circumstances like or similar to those about which you have heard evidence in this case. If you believe from the evidence that the Urgent Care Center failed to comply with this duty and that such failure was a substantial factor in causing Ms. Warren's injuries, then you will fine for the plaintiff. Otherwise, you will fine for the defendant, the Urgent Care Center. I'd like to do closing arguments, please.
Ladies and gentlemen of the jury, we have before us a case where telemedicine could have helped prevent a case of extreme emotional distress. The defense will argue that this is all it is, one patient having to suffer from a traumatic experience because of lack of telemedicine. But ladies and gentlemen, we both know this is more than that. This is a case that sets the precedent on whether telemedicine could become the standard of care, whether telemedicine could and should become an option in rural areas to provide care and is something providers should viably use. This is a case that determines whether urgent care centers and other rural entities can merely just say telemedicine is not part of the standard of care and what they provide. In making this decision, I urge you to consider how prevalent and possible telemedicine has become, the efficiency and safety of telemedicine, and lastly, that if you make a decision today that the defendant is not culpable, you'll be setting a precedent that telemedicine need not be a viable option for care in rural areas. Thank you.
Good morning, ladies and gentlemen. On one issue, I'm sure we can all agree. Everyone, including ourselves, can be delighted to know that Ms. Warren did not, in fact, as it turns out, suffer a stroke. Instead, she was left with a benign, self-limited condition called Bell's palsy that goes away with time. We're delighted that it has. I'd like to spend the majority of our time here in these closing remarks on two issues, on both of which the plaintiff, that person over there, has the burden of proof, meaning that she has to persuade you that she's right and we're wrong. If she fails to do that on either of these two issues, causation and standard of care, she loses, and the only verdict that you can reach is for the defense. If she loses on both, all the more so. And I say she does. Why? Let's turn first to the question of causation. The theory that we've been presented with here is that had telemedicine been offered, somebody better at reading CT scans than Mary Jones, my client, would have avoided a helicopter ride. The problem, however, is that that conclusion requires nothing but speculation. We have no way of knowing who this mythical reader would have been, what qualifications he or she may have had or may not have had, how sleep-deprived or bleary-eyed or overworked that person may have been, and he or she may have reached exactly the same conclusion that Ms. Jones did, in which case the helicopter ride would have been necessary anyway. To conclude otherwise is to speculate contrary to the law. There is no basis then to claim that but for the lack of telemedicine, the outcome would have been different. Now, counsel has tried to suggest through cross-examination that we don't know what would have happened had the patient been transported either. Well, admittedly, we don't know that for sure. But what is more likely? That an entire academic medical center with all of its resources, human and technological, would miss a diagnosis such as this, or that some harried resident in the middle of the night, bleary-eyed from lack of sleep, might miss a CT scan. I think that's pretty clear. I don't think there's a causation case here, and if there isn't, case is over. The only possible verdict is for the defense. But I want to spend the majority of my time on the standard of care question. It is the plaintiff's burden to prove to you, to satisfy you, that St. Charles Urgent Care Center breached the standard of care and that Mary Jones, my nurse practitioner client, did as well. Let's consider first the Urgent Care Center. I note, and I emphasize this, in her closing arguments not 3 minutes ago, counsel suggested to you that the standard of care should require telemedicine in services such as this. Should, ladies and gentlemen, is not the same as does. All that is required of a defendant in a case such as this is reasonableness, not perfection, not ideal care, not whatever they do at the Mayo Clinic, mere reasonableness. And what is the yardstick by which you are to judge whether the care was reasonable or not? The answer to that is clear in the law. The answer is what other urgent care centers in Kentucky do under the same or similar circumstances. And what is the uncontradicted evidence on that point? That 90 to 95% of the urgent care centers in Kentucky do not offer telemedicine. So either you reject that theory or you come to the conclusion, as the plaintiff's logic compels you to do, that between 90 and 95% of all the urgent care centers in Kentucky are breaching the standard of care every day of the week. Now, the court has instructed that you're entitled to use your common sense. It cannot possibly be the case that when the yardstick for comparison is what other urgent care centers do, And when 9 out of 10, if not 19 out of 20, do exactly what the St. Charles Urgent Care Center would do, that somehow there's a breach of the standard of care. There is not. Let's turn then to Ms. Jones. Mary Jones is a nurse, specifically a nurse practitioner who devotes her life to the care of patients, as she did in this instance. She was hailed into court here because she got the diagnosis wrong. But again, the standard of care does not require an absolutely accurate diagnosis. Not even Dr. Darling claims to do that. The standard of care simply requires reasonableness. Now, what we just heard was from Dr. Darling was that the distinctions between a Bell's palsy on the one hand and a stroke on the other are subtle. That's his word, not mine. Subtle. Does the standard of care demand that a nurse practitioner make a subtle distinction such as this? I think not. There's been no testimony that would suggest that that makes any sense. Why? The evidence is, and that's what we have to rely upon here, that stroke is 25 times more likely than Bell's palsy, just epidemiologically, just on the basis of population. It is unreasonable to ask anybody, including Mary Jones, to make that kind of distinction, particularly because the cost of missing a Bell's palsy is substantially zero. Bell's palsy takes care of itself. It goes away. It leaves the patient intact and neurologically whole. The cost of missing a stroke, in contrast, is dire. It could very well, and often is, be fatal. And if it isn't fatal, it may leave somebody unable to walk, unable to talk, unable to see, unable even to care for his personal hygiene. You could reduce a vibrant, fully functional human being to someone who is nowhere near in the same shape as before. And remember, the evidence, again, is uncontradicted that Bell's palsy is much more common in younger folks than Ms. Warren was when she presented to Mary Jones. Stroke, on the other hand, is more common and, according to Dr. Darling, no less, doubles with every decade after 55, and Ms. Warren was 64. On the one hand, there's a chance of missing a diagnosis that leaves no harm. On the other is the chance of missing a diagnosis that could result in a fatality or in a neurological, to use his own words, catastrophe. Erring on the side of caution, Ms. Jones had the courage and the humility, the bravery to request a transport to a place where more definitive care could be provided if indeed it was needed. The same spirit that allowed her to determine that she would accept the limitations and challenges and risks of providing services to a population in a small town otherwise unserved, in the highest traditions of the nursing profession, led her to err on the side of caution in behalf of her patient and take the chance that the ride might have been unnecessary lest some disaster be avoided. That, ladies and gentlemen, is not a breach of the standard of care. That's the kind of care we should encourage and applaud. It is not the kind of care that requires or permits any verdict but one. The verdict I ask you to bring in is for the defense. Thank you very much.
Please recall the jury instructions given to you prior to closing arguments. Could I have the verdict form A, please? I'll just restate. It was the duty of the St. Charles Urgent Care Center in acting through its clinical staff to exercise toward the plaintiff that degree of care and skill which is expected of reasonably competent medical personnel acting under circumstances like or similar to those about which you have heard evidence in this case. If you believe from the evidence that the Urgent Care Center failed to comply with this duty and that such failure was a substantial factor in causing Ms. Warren's injuries, then you will find for the plaintiff. Otherwise, you'll find for the defendant, St. Charles Urgent Care Center. Please take a moment to make your selections. Also, the jury shall not consider this court's technological savvy and situs at the renowned Mid-Atlantic Telehealth Resource Center's 2018 annual conference, an endorsement or preference for any particular outcome. It was the duty of Mary Jones, MSN, to exercise toward the plaintiff that degree of care and skill which is expected of a reasonably competent clinician acting under circumstances like or similar to those about which you have heard evidence in this case. If you believe from the evidence that Mary Jones failed to comply with this duty and that such failure was a substantial factor in causing Ms. Warren's injuries, then you will find for the plaintiff. Otherwise, you will find Yeah. Ms. Horn's injuries, then you will find for the plaintiff. Otherwise, you will find for the defendant, Mary Jones. All right, could we get question 1 on verdict form A? Aha, okay. Could we get question 2, verdict form A? I assume we'll see something similar in the next. Could we get question 3? Do we get question 3? I think we...
Well, technically, if the answer to question 1 is no, then questions 2 and 3 become unnecessary.
Yeah, true. Okay, can we get question 1, verdict form B? Yeah, see, I knew somebody would pick a number. $500,000 for being traumatized by a flight in that helicopters, I think it's fair. However,
Objection, Your Honor.
this is question 1, verdict form B? Okay. All right, so the jury finds for the defendant.
Thank you, Your Honor.
You're welcome.
Thank you, ladies and gentlemen.
How long have you been in telehealth? So I don't know who that's directed to, so maybe Joe start.
I don't know, 25 years or so.
As an active practitioner, I've been doing it for 10 years.
10.
I would say for me, 2 answers. As a ER practicing physician, approximately about 10 years, including my training and stuff. And then as far as a telehealth business owner, just about 6 months.
Ty?
About 1.5 years as a practicing attorney.
And I would say now, let's see, about 4 years for me. Telestroke hubs train nursing staffs at spikes before they start telestroke centers. Is that correct?
Hello, everyone. Morgan Boyer with Penn State Health. So yes, any strong network will go out and they train the physicians as well as their own physicians, as well as the nursing staff, and any ancillary staff that might be involved in the process. 100%, you will always have that training. Anything else?
So,
No, that's
so that was
fine.
supposed to be spokes, not spikes?
Yes, but I thought that was cute.
Oh, right. Can telemedicine be used while in transit on a helicopter? The helicopter ride would be unavoidable, but if telemedicine were successful, expenses after transfer could have been avoided.
The answer for that is yes. A shameless plug, but our device does operate over Wi-Fi, 3G, 4G, even satellite. So there are options out there. I know that we're not the exclusive answer for that, but yes, that is a true statement.
And we do it all the time as well in our practice.
It's also possible to do ultrasonographic imaging from moving ambulances to hospitals, which is not the same thing, but can be useful anyway.
Does this verdict devalue telehealth, stating it is not standard of care?
That's a good lawyer question.
If it does, then we're all here to say mea culpa. No, this whole thing was invented, and I think we made clear in the notes that everybody up here has made statements, taken positions that may or may not reflect what he actually believes. It's a play, it's an act. And I do think, well, first of all, I think that as a lawyer, I am not in a position to tell anybody what the standard of care is. That's what doctors and nurses do. But second, there is certainly evidence to suggest that at least with respect to telestroke, the standard of care, at least in many places, should reflect the availability of telehealth as a technology and as a way of improving outcomes. But again, in spite of what Rob Darling says, it actually is a doctor's question and not a lawyer's. We define what the standard of care is in a legal sense, but it's through the testimony of experts and ultimately the decisions of juries that the standard of care is actually defined.
And I think where we're headed too, the word telemedicine is probably going to go away. It's just going to be medicine with time, as it really, with what we're going through right now, all these changes in healthcare. It's just going to be one of the tools that we use to take care of patients.
I'll add one additional statement in there, and that's the fact that this case really stemmed from a patient that I had that was transported to me in my base hospital level 2 trauma center, that I think really with telemedicine, I mean, that's how Joe and I came up with this case together, is probably didn't need to be transported to me. And so where's the value for telehealth? I think it's not, obviously, it's not the standard of care. We're not at the position where it's, it's a criminal or legal matter right now, but can we do better for our patients? That's the question we get to ask outside of a courtroom. Is it better for our patients to be able to have more resources? And I think that is unquestionably yes.
I think also this is a good example of what we'll probably see coming, more trials, more medical malpractice cases that have shades of telemedicine, if not based on, use of it or failure to use it. This is sort of the future that we're heading to your point. This will be medicine, and we'll decide at what point telemedicine gets woven into the standard of care. We did have an interesting question that I can't answer. This is a pattern today. If an institution decides to dismantle their tele-ICU after having it as a standard part of their treatment toolkit, are they liable for delays in care or poor outcomes?
Well, they're liable to the possibility that some creative plaintiff's lawyer out there is prepared to so contend. The standard of care is not what is done by hospital X or Y or Z or Dr. A or B or C. It is what is done by reasonably prudent, or in Kentucky, reasonably competent practitioners or institutions of the same type in similar circumstances. So if I'm defense counsel and Parrish thought I should be anything else, if a client had that service before and then abandoned it, what I'm going to try to show in that case is that in spite of its decision to change, the standard of care did not require when it was started and does not require today that a tele-ICU or anything else for that matter was required by the standard of care, because other reasonably prudent hospitals do not offer that potential capability. If I'm the plaintiff's lawyer, perish the thought, then what I would do is I would argue by their own conduct, the defendant has admitted that the standard of care demanded that there be tele-ICU services, and probably to put profits over people and to save money and to hell with the lives of human beings, it subjected my poor patient, my poor plaintiff to this terrible chain of events for which we deserve $47 million now. But then I'm not biased.
Are you aware of any case in a state with a finding of a duty to provide telehealth when it wasn't provided, like in this case?
No published cases, none that I've been able to find. In fact, there have been extremely few medical malpractice cases of any variety on any theory that have been published in the United States. There have been reports of cases that have been settled out of court, many of them subject to confidentiality clauses that prevent the parties to that case to discuss it after the fact. There have been quite a few cases brought by prisoners against those who provide telemedicine services in a correctional setting. And those are not true medical malpractice cases. They're a form of civil rights case. There's a federal statute that says that a doctor or any institution that is providing care in this fashion is liable if it fails to, or if it can be shown that there was, this is pretty much a quotation, deliberate indifference to a serious medical need. That's a very heavy burden for a plaintiff to carry, particularly since the majority of the prisoners are pro se litigants, meaning they proceed on their own without the benefit of counsel. It's very hard to win those. Occasionally they have, but they're really not medical malpractice cases. They're really civil rights cases and are really not pertinent to this discussion. So the answer is no, I haven't seen any holding like that. I haven't seen any holding to the contrary, and at least as far as I've been able to determine, published cases of any claim of any sort against telehealth providers are simply not to be found, or at least if they are to be found, it takes someone with better research skills than I possess.
Joe, are you aware of any cases related to remote patient monitoring whereby the physician had access to information and didn't use it and there was a bad outcome for a patient?
I'm not, which doesn't mean that there weren't any, but I've not been able to find any, on any other theory of distance care. I'm sure they're coming, but I haven't seen them yet.
You think malpractice carriers see this coming?
I imagine they do, but what's very interesting is that in the early years, it was often the case that telemedicine was expressly excluded from policies of insurance. And over time, that became increasingly unusual. And now not only is telemedicine covered by most med-mal policies, but the premium charge to the doctor offering that service is no higher, or at the very least not much higher, than is the case when he confines his care to in-person services only. So far, the insurance industry has not seen this as a big threat. Let's hope that continues.
Yeah. Interestingly, physicians who are licensed in multiple states and seeing patients in multiple states, it gets a little bit tricky with them, with their malpractice carrier, depending on how many states that carrier is available in. And physicians would do well to check their policy to make sure that if they're practicing in Virginia and they see patients in North Carolina and Kentucky and Delaware and the rest of the matrix states, that their policy doesn't say, yeah, we'll cover you for telemedicine at this great rate, but as soon as you see a patient in North Carolina, you're out of luck. Not germane to this discussion, but watch out.
We want to thank our panel, and we thank you for listening in, and for those of you who read ahead, because that probably helped you understand, and if you didn't understand, it's probably because you didn't read ahead. Just putting that plug in. So thank you all. Please fill out your evaluation form that's in your app about this. This is our first time trying this kind of little experiment, and so we would like to know, did it work for you? Was it useful, thought-provoking, good discussion starter? As these guys come off the stage, and let's give them a hand. Before we go to our break, I wanted to introduce you to our fellow Telehealth Resource Center. This is a national Telehealth Resource Center, so we can get them up on video. They are actually in the exhibit hall, and they are putting together a telehealth technology showcase for you all. And this is also a HRSA-funded center. And they will introduce themselves.
Good morning. My name is Doris Barta, and to my right I have Jordan Berg, and then also Becky Sanders is helping us from one of the other TRCs. And we want to thank you for giving us the opportunity to do the telehealth showcase here at your telehealth conference. We have a system of equipment set up in the back of the room, and Jordan's going to go ahead and explain to you what we have. We hope you'll come by and take a look at what we have here for you to play with. Jordan?
Hello, everybody. We're going to switch you over to our exam cam so that you can kind of see what we've brought along. This is actually one of the devices that we're going to be demonstrating. We're going to try to pan slowly so nobody gets seasick. But we're going to show you the three different tables we have. At the first table here, we've got our exam cam station. So we've got several different exam cams with multiple different tips and heads for us to try out. The next station we have here, we've got video conferencing equipment. So we've got a couple different video conferencing setups. And at the end of that table there is our mobile health. So we've got stethoscopes, otoscopes, and a variety of dermoscopes. So if you're interested in dermoscopes, definitely come by and take a look at that. And finally, our last station here is our auscultation station, our stethoscope station. We have 4 different stethoscopes we have for you today. And then we've got Sam. We travel everywhere with Sam. Sam is our unofficial TTAC mascot. You can actually listen to him, feel his neck for a pulse, and actually be able to hear kind of what's going on inside of his heart and lungs. The whole setup is very hands-on. We encourage you to come by. If you signed up for a particular time, come by at that time. But if not, just feel free to drop by, and we'll try to fit you in if we can. So we're really excited to be able to talk to everybody and see you guys come by.
So TTAC is based out in Alaska, and their whole goal for under the HRSA grant is to help people assess technology, and they keep an innovation watch as well. So they have a great number of things that are kind of coming down the pike that they can also talk to you about. And they are a free resource for you all as well as they serve as a resource for the telehealth resource centers.